Hello everyone, my name is Mr. Stomach and I am the resident heavy-duty blender and mixing bowl of your digestive system. If you want to find me, I am located in the upper left quadrant of your abdomen, tucked right underneath your diaphragm and slightly covered by my neighbor, the liver. Shape-wise, I am a hollow, muscular, J-shaped organ. When I am empty, I am quite small and wrinkly inside. But because I am incredibly distensible, stretchy, I can expand to hold up to 1 to 1.5 liters of food and liquid after a big meal. In the medical world, you will always hear me referred to using the root word gastric, like gastric juices, gastritis, or a nasogastric tube. If it says gastric, it's all about me. The anatomy, inside and out. To understand how I work, it helps to look at how I am built. I have 4 main regions and a very unique muscular wall. 1. The 4 main regions. The cardia. This is the tiny entrance zone where food first arrives after traveling down the esophagus. The fundus. The rounded, balloon-like upper dome that sits next to the cardia. It collects gases produced during digestion. The body. My largest central region where most of the heavy mixing and churning happens. The pylorus, the funnel-shaped bottom exit that funnels food toward the small intestine. 2. The sphincters, the gatekeepers. I have 2 muscular valves that act like security doors to keep things moving in one direction. Lower esophageal sphincter, cardiac sphincter, located at the top where the esophagus meets the cardia. Its job is to open to let food in, then slam shut so my highly acidic contents don't burn the esophagus. Pyloric sphincter, located at the very bottom exit. This valve acts like a strict bouncer, opening just a tiny bit at a time to let small amounts of digested food pass into the duodenum, the first part of the small intestine. 3. The muscular wall and rugae. While most of the digestive tract only has 2 layers of muscle, I have 3 layers running in different directions: circular, longitudinal, and oblique. This allows me to twist, squeeze, and knead food vigorously. When I am empty, my inner mucosal lining collapses into deep accordion-like folds called rugae. As you eat, these rugae flatten out to let me stretch without tearing. The major functions of the stomach. For your nursing exams, you can summarize my primary responsibilities into 3 mechanical and chemical actions: storage, mechanical digestion, and chemical digestion. 1. Temporary storage reservoir. I prevent you from having to eat continuously. Instead of food moving immediately into the intestines, I hold on to it for 2 to 4 hours, gradually processing it so the intestines can handle it at a controlled pace. 2. Mechanical churning, making chyme. Through the coordinates of my 3 muscle layers, I physically smash, pummel, and grind solid food into a smooth, semi-liquid mixture. Nursing term. Once solid food is mixed with my acidic juices into a liquid state, it is no longer called food, it is legally called chyme. 3. Chemical digestion. My inner walls are lined with millions of tiny microscopic dips called gastric pits, which contain specialized cells that secrete gastric juice. Parietal cells, hydrochloric acid, and intrinsic factor. These cells secrete hydrochloric acid, HCl, making my internal environment highly acidic, a pH of about 1.5 to 3.5. This intense acid kills harmful bacteria you might accidentally swallow and unravels proteins so they can be digested. Critical nursing concept. Parietal cells also secrete intrinsic factor, a protein absolutely required for the small intestine to absorb vitamin B12. Without me releasing intrinsic factor, the body cannot make red blood cells, leading to a condition called pernicious anemia. Chief cells, pepsinogen. These cells secrete an inactive enzyme called pepsinogen. Once pepsinogen hits the highly acidic HCl, it activates into pepsin, the primary enzyme responsible for breaking down proteins into smaller peptide chains. Mucus cells. Because my acid is strong enough to burn through metal, I have specialized cells that coat my inner lining with a thick alkaline mucus layer. This shield neutralizes the acid right at the tissue wall, preventing me from digesting myself. Common stomach diseases. When my protective mechanisms fail or my valves stop working correctly, several classic clinical conditions can occur. 1. Gastroesophageal reflux disease, GERD. If the lower esophageal sphincter becomes weak or relaxes inappropriately, my highly acidic gastric juices splash upward into the esophagus. Because the esophagus doesn't have a protective mucus shield, the acid burns the lining. Nursing connection. Patients describe this as heartburn. Over time, chronic exposure to acid can alter the esophageal cells, a precursor condition known as Barrett's esophagus. 2. Gastritis and peptic ulcer disease, PUD. Gastritis is an acute or chronic inflammation of my mucosal lining. If that inflammation worsens and the protective mucus barrier completely breaks down, the acid begins eating away at my actual tissue wall, creating an open sore called a peptic ulcer. The common culprits. 1. H. pylori, a spiral-shaped bacterium that burrows into the mucus lining and damages it. 2. NSAIDs, medications like ibuprofen or aspirin block the body's production of prostaglandins, chemicals required to maintain that thick protective mucus shield. Image comparing a healthy stomach lining with an area affected by a gastric peptic ulcer. 3. Gastroparesis, delayed gastric emptying. Paresis means partial paralysis. This is a condition where my muscles don't contract normally, causing food to sit in the stomach for way too long instead of moving into the small intestine. Nursing connection. This is very common in patients with long-standing diabetes because high blood sugar can damage the vagus nerve, which tells my muscles when to squeeze. Symptoms include nausea, vomiting, undigested food, and feeling full quickly. Critical nursing implications and assessments. The NG tube danger. When a patient has a nasogastric NG tube hooked up to suction, the nurse is pulling out my highly acidic gastric juices, HCl. If you pull out too much acid, the patient's systemic pH rises, throwing them into metabolic alkalosis. Always monitor electrolyte levels, especially potassium and chloride. GI bleeding presentation. If a peptic ulcer begins to bleed, the blood interacts with my stomach acid. The acid digests the blood, turning it dark brown and clumpy. If the patient vomits, it looks exactly like dark wet coffee grounds. This is a classic nursing sign called coffee ground emesis. Dumping syndrome. If a patient undergoes a gastric bypass or gastrectomy, removing part of the stomach, they lose the pyloric sphincter bouncer. High carb food dumps rapidly into the small intestine, drawing in massive amounts of water. The patient will experience sudden hypotension, dizziness, sweating, and severe diarrhea shortly after eating.